Hello, I'm Dr. Richard Senelick, and I'm a neurologist who specializes in neurorehabilitation. And in this lecture, we're going to cover brain injury and predominantly moderate and severe traumatic brain injury, because in another lecture, we cover concussion and mild head injury. So let's see if we can get our slides to move. There we go. If we think about all comers, all brain injuries, there's a lot of them, 2.5 million each year. About a little over 250,000 are hospitalized. And we're going to talk about this subset because most head injuries, which is part of another lecture, are mild head injuries, concussions, which are a big problem, so that they deserve a whole nother lecture. But we, in the rehabilitation side, see a lot of people with severe and moderate traumatic brain injuries. Let's sort of compare it to other diseases because I don't think it gets the attention. Usually if I'm lecturing to an audience, and let's say there's 300 people in the audience, and I ask for a show of hands of the women, how many people worry that they could get breast cancer? How many people know somebody who's had breast cancer? Lots of hands go up. How many people think or worry that they're going to have a heart attack? Could have heart disease, diabetes, lots of hands. But then you say, well, how many people think it would have a traumatic brain injury? And a few hands go up. And how many people know somebody? Maybe a few more hands. But look at the comparison of how common mild head injury, concussion, all brain injury is. And even if you take the 100,000 moderate to severe traumatic brain injuries, or the 250,000 that are hospitalized, and you can see that it's sort of a population that probably doesn't get the attention that it deserves. We come down here to spinal cord injury, and all of the rehab hospitals, the therapists love treating spinal cord injured patients. They're young, they're cognitively intact as a rule, and lots of physical disability to work on. But it's 17,000 patients compared to, let's say, that 100,000 of moderate to severe. Or somebody says, well, we need to have an MS program. And MS it's an important disease. And particularly now we have disease-modifying drugs for decades that make a huge difference. And you can see how much smaller the number is. So that we don't really think about traumatic brain injury as something that's going to happen to us or our neighbor, and how common it is. Now, we're going to talk about sort of the causes and things that are involved. And unfortunately, alcohol is involved a good deal of the time in the person who is driving or falls, has an accident at work or in the home, particularly as we get older. Alcohol is involved, look at that, 30 to 50% of the time. Or the poor person who's jogging along the side of the highway, riding their bike in a car, and then is hit by somebody who is intoxicated. So alcohol continues to be a major problem, period. I could just stop there, but particularly when it comes to traumatic brain injury. There's a bunch of studies to show the effect of alcohol, and I was always be amazed when I would take care of somebody who had had a traumatic brain injury or was involved in a terrible car accident. And they might even say, well, boy, it was a good thing I was ejected, that I was thrown out of the car and didn't have my seatbelt on, because had I stayed with the car, I would have died, which is, craziness, because seatbelts and airbags save an enormous number of lives. Or I've had patients tell me, yes, I had a lot of alcohol on board, but that's why I was so relaxed and why I did so well. Well, the truth is that alcohol is a toxin, and we know its effects on the brain without an injury, cerebellar atrophy, dementia, all kinds of problems. Combine it with now you're intoxicated and you have a traumatic brain injury, you're going to do worse. So when someone tells you, well, boy, it was a good thing I was relaxed and loose and all that during that, it's nonsense. They may have gotten lucky. So Let's look at moderate to severe traumatic brain injury. Most of them are falls, and we covered this. I have another lecture. You're going to see how things overlap. We did a lecture on how does TBI affect aging, and you'll see some of these results there with different graphs. So falls are pretty common, and particularly as we get older. Can be a work-related fall, can be a fall off a ladder, which is pretty common at home. And brain injuries, as we'll see in just a little bit, are acceleration, deceleration injuries. So if I'm standing and I slump to the ground, well, that isn't a lot of acceleration, deceleration. On the other hand, if I've got my hand full of packages and I trip, and now I do what you might call a face plant, and I'm, let's say, 6 foot tall, now I'm accelerating from 6 feet in a straight downward fashion, and those injuries are much more significant. We all know motor vehicle accidents, a big issue. Airbags save lives, save more lives certainly than problems they cause, but particularly in our elderly population, we can see traumatic brain injuries from the airbag hitting the head. The small little tiny blood vessels that we cover in our stroke lecture, the lenticular striates deep inside the brain, can get torn in automobile accidents and cause strokes. Struck by, against events, hit by something, and then assaults. It kind of depends on where you live. I used to refer to this as the local knife and gun club. So in many communities, that's a tiny number, and in other communities, it's a big number, and clearly age-related. I believe I showed that in a previous lecture, that young people are much more likely to have a brain injury from an assault than older people, although I've seen it in, unfortunately, nursing homes where a demented patient wanders around and then assaults an elderly person and causes a brain injury. Very unfortunate situation, not common, but can happen. So divided by age, I'm certainly in this column here, over 65, and most of you are probably under 65 if I'm talking to therapists and nurses at rehab hospitals. So let's look at falls. Wow, big number in the older crowd, right? So it's the big cause of mild head injury. We just switched from moderate and severe to mild. And we have fall prevention programs, right? Lots of articles, fall prevention programs. It's in the American Heart Association, American Stroke Association, of what should take place in rehab after a stroke, and you should have a fall prevention program. One of the most important things you can do for your parents and grandparents when you go through their house is, get rid of all the extension cords, buy them a bunch of night lights to light up the path to the bathroom. Throw rugs. Throw rugs are hard to get rid of, particularly if they're nice antique oriental rugs. A lot of times it's hard to convince people that those runners need to be gone. And you can see it's much less in the younger group. Car accidents, well, as we get older, we're not driving as much. But we do get involved in pedestrian accidents, both because maybe if we're the driver and our reaction time is bad and we're still driving and our vision isn't as good and we don't see the pedestrians. And so we see a lot more of these in retirement communities. You might see a lot more pedestrian accidents in Florida, Arizona. And if you're the pedestrian, inattentive, can't see as well, step off the curb at the wrong time, got confused by the changing light. And as we talked about, assaults, pretty rare in the older crowd and much more common here. And sports head injuries, mild head injuries, which we have this whole lecture on concussion coming up, maybe zero. And you can see much more common as the younger crowd. So how good are we at predicting outcome? And I cover this in a number of lectures where we talk about our bias and are we any good at this, particularly in traumatic brain injury? And I just, I'll kind of weave it in here if I can, because I just reviewed an article and I'm writing a review of it. of how good are we at predicting outcomes and deciding on withdrawal of treatment in patients with moderate to severe traumatic brain injury. If you look at the literature, there's been lots of variables to try and predict outcome. Post-traumatic amnesia is that period from the accident until someone has continuous memory. And really, if it's 24 hours that they still are having trouble, now we're into a severe traumatic brain injury. And we see this all the time, right, in the hospital, where a patient tells the family, my doctor hasn't been by, never sees me. Nurses don't come in at all because they have no continuous memory. They can't remember from moment to moment. The Glasgow Coma Scale, well, that kind of depends on when you're evaluating it. The one we care about in grading mild, moderate, and severe brain injury is once the patient is stabilized in the emergency room. So they may be out on the highway, bad car accident, he had a pneumothorax, so their oxygen level's low, maybe a spleen injury, and they're bleeding. And so they look much worse as far as their cognitive problems. Once all that's stabilized, their Glasgow Coma Scale is much higher. So we care about the one once the patient's been stabilized. A lot of the variables look at is MRI, CT, how big is the lesion, amount of contusions, length of time in a coma predicts outcome. Although most patients wake up, it's over 90% of patients who are initially comatose will wake up and follow directions. Younger people do better than older people, and pupillary responses that's been looked at really doesn't help very much. So this was a study looking at predicting outcome after severe traumatic brain injury, a little tongue twister there. This was an article by Choi, and they looked at the best Glasgow Coma Scale, best motor response, pupillary responses. Remember I said those aren't very good. And they were only good at predicting outcome like 3/4 of the time. And in another study, Feldman found about a 60% accuracy in predicting, and this is really kind of, death, awakening, following commands. This isn't higher level quality of life, being able to do your ADLs type stuff. And so 30% of the time, the prediction was wrong. And so that's unacceptable if we're going to decide on withdrawing care and saying, well, based on my experience or my bias, I don't think these patients do well. And this paper I just reviewed yesterday shows that, like I said, better than 90% of the patients wake up and follow commands, and people do much better. And we need to be very cautious before we make any withdrawal of life support decisions or life supportive care, whether the patient should go to rehabilitation in these severely and moderately severe traumatic brain injury patients. How about the really vegetative? Really vegetative? That's not very good, but what I want to say was really impaired patients. And so persistent vegetative state, these are the patients that are comatose, but they may open their eyes, look around, they have normal sleep-wake cycles, and they usually have brainstem problems or diffuse hypoxic injuries. But this was 1-year outcomes on patients in a vegetative state. And how long did the vegetative state last? And here, the purple arrow, you can see that at 1 month, 36% became conscious, 3 months, another 20%, at 6 months, another 16%. So most patients emerge. Now, do they still have significant cognitive, behavioral, and physical deficits? Yes. Is that a quality of life acceptable to that family and that patient? Well, that's a whole nother lecture, which we cover a little bit in other lectures, for that individual family to make. But it's interesting that most patients in a vegetative state, the majority emerge. Now, the percent that are independent, that's below the red arrow, only 21%, and they were all young people. Now, 9% of the 20 to 39, and you can see that older people wasn't an issue. Now, I have seen lots of young people in persistent vegetative state who are well past a year out. So you can see that the percentages don't go well with you if you haven't awakened within, I'd say, that first 3-month period. So prognostic factors should not be used to treat or not treat in the beginning, but instead act as guidelines for treatment and expectations. So that after a time, month, 2 months, what is the right amount of time to wait? Is it 2 weeks, 2 months? To say, gee, I think if there's going to be progress, it's going to be very slow. But certainly in the beginning, one should not withhold life-saving treatment, and one should not withhold rehabilitation based on this belief that, I've seen a couple of these patients and, I don't think they're going to do well. That's a bias that we need to avoid. Patients are doing much better. We've seen much more of these. In the 70s, the survival rate of a severe traumatic brain injury was only 50%. And one of the things that really came out of Vietnam War was helicopters, major trauma centers. Every major community has a level 1 trauma center. And if you're a rural community, you have access to it via life flight. And now the survival rate is 70%. We all see helicopters landing, on the highway, picking up patients, and their ability to intervene of quite early. This was another study, big study, 15,000 patients of severe traumatic brain injured patients. I always wanted to be the one to come up with the names for medications. Don't you love it? A lot of X's and Z's these days in medicines. But here's a study on traumatic brain injury. One was called Impact and the other was called Crash. And they have to come up then with words that'll fit in there. But said, well, what happens at 6 months to patients who initially are severe traumatic brain injury, and with maybe MRI and CT lesions, they're unresponsive, have a low Glasgow coma scale. So a fourth of the patients died. Only at 6 months, you can see the very low figure, only 4% remained vegetative. 16% had a severe disability. So we'll add those up 20, that's about half. Those for top 3. I think it's 48%, let's call it 50%. So 50% are not going to have a good outcome. Now, the severe disability, we can argue about in that some patients, some families would say, yes, that's acceptable to us. But the key is moderate disability to good recovery. Look, a third good recovery, 20% moderate disability. And this is why, reinforcing what I just said, the previous slides, we need to be very careful when we say, well, we don't think this patient needs rehabilitation. We don't think they're going to do well. Let's wait. Let's withhold aggressive therapy at this time. Your bias or decision may be affecting the outcome. Oh, time for a little anatomy lesson. These are autopsy slides. All of us watching this should be medical professionals. Shouldn't be bothered. You may have seen these before. So this is on an autopsy table. This is going to be the scalp pulled back, front here, posterior here. These little lines are sutures. So the baby's soft spot would be right here. These sutures don't fuse until somewhere between 16 and 21, so the skull can grow. And as the brain grows inside, then the skull grows with these little expansion joints. And what we're going to do is take a vibrating saw and we're going to cut around and take this off, and we're going to set the skull, the top of it, just to the side. You can see let me get my pointer back, set it over here. This is what the brain looks like in the fresh state. Many physicians, nurses, therapists who evaluated brains did them after they were fixed in formalin, and maybe it's a month later when you're looking at them. But this is what the brain looks like in the fresh state. Down here is a tough leathery membrane called the dura. So it's between the inside of the skull and the brain. Underneath it is the subdural space. So we pulled it back. The shiny lining is the arachnoid. So something underneath the dura and on top of the arachnoid is subdural, and I'll show you some subdural hematomas. The spinal fluid is in the subarachnoid space. You can see some fluid here where we've peeled back the shiny arachnoid. And then the pia, the third one, is just applied right sticking on the brain. You can't pull it off. You can like see it microscopically. So a subarachnoid hemorrhage, and I'll show you a picture of that when the aneurysm breaks, is in the spinal fluid underneath the arachnoid. And you can see that the brain doesn't fit tightly in here. There's space, so the brain can move. And as the brain shrinks with age, there's more space. And when we talk about subdurals in the elderly particularly, there's little tiny blood vessels that stretch in that area. I think we covered that in the TBI and aging lecture, and they can tear. The other interesting thing to note is up front here, it's thick, the skull is going to be thick in the back. You'll see that when I take the brain out. And on the side is going to be thin. So the most dangerous blows and most skull fractures are over here in the base of the skull, where the skull is the thickest, and up here it's where it's the thinnest, excuse me. And up here, the thickest, we don't get so many skull fractures. We're going to now gently take this brain out, and we're going to take it and put it aside, put it in some formalin to sit for maybe 3 or 4 weeks before we're going to start to cut it open. So now we've pulled it out, and we can look inside and see how thick the skull is here and how thin it is here. There's an ear under here and an ear over here. So this is the base of the skull, so a basilar skull fracture. And if there's a fracture through here, you may look in the ear and see if there's blood behind the eardrum. Blows to the side of the head, like in boxing, can be the most lethal because of how thin the skull is. And look here, it's nice and thick in the back again. So the frontal lobe sits up here. We're going to jump down into the middle fossa. Temporal lobe sits here. We're going to jump down into the posterior fossa. Cerebellum and brainstem sit here. We'll get a better view. The olfactory bulbs are right here. So if you were to take a pencil and push it up your nose, don't do it, it would end up here. And I'll show you a better picture of the olfactory bulbs. That's what we smell with. And it's very common for people with severe brain injuries to lose their sense of smell. This is the optic nerve. The eyeballs are sitting under here. Carotid artery, pituitary gland. And these things that look like little pieces of linguine, these are the cranial nerves. Remember, there's 12 cranial nerves. And they go a long way, and they get stretched in brain injury. So that if the brain gets stretched, so can the cranial nerves, and someone can end up, there's 3 of them that go for eye movement, and you can end up with double vision. And then as the stretching goes away, the double vision may improve. Now the 7th and 8th nerve, down in here for hearing, okay, and facial movement, so you get facial paralysis, goes right through here. And remember we said common to get skull fractures through here, so people may get a facial palsy or lose their hearing. Look how small the spinal cord is down here. That's why spinal cord injuries are so devastating, because all of that information from both sides of the brain that has to go down to the rest of the body goes through this small area. This is the foramen magnum, and more dura pulled back, tough leathery membrane. I think we've done enough here. Well, let's look at another one. So we turned the brain over. This is the front of the brain. This brain has been fixed or in the formalin. And these are those olfactory bulbs. Okay, we heard a lot about them this last year with COVID, right? As that maybe that's a potential place for entrance of the virus into the brain, and people lose their sense of smell. because they sit with little hairs right at that base of the brain. This is the optic nerve went here. This is the optic chiasm, splits basilar artery, vertebral arteries. Here's the brain stem here. An important thing to kind of see, we'll talk about a little later. So here's the uncus of the temporal lobe. And let me go back. Am I going up? Sure. So the temporal lobe sits here. When we talk about herniation, when a brain swells, it's got no, it can't, can't go out. This is a tough bone. So where does it go when it swells? It goes here. And that uncus that I just showed you herniates over this edge. The third cranial nerve sits right here, and it has the pupillary constrictor fibers. That's why people get a blown pupil. But also the brainstem gets pressed on. Here's that uncus going to swell. Here's the brainstem. People herniate and stop breathing, and then have an arrest, because the areas for here's the medulla, the areas for heartbeat and respiration sit down here in these critical structures. So let's talk about the mechanism of severe traumatic brain injury. They're predominantly acceleration, deceleration injuries. I alluded to that. You're going 60 miles an hour, your car's going 60 miles an hour, and now it hits a cement pillar and stops suddenly. And your airbag goes off. So you don't hit the steering wheel, but your brain inside was still going 60 miles an hour, and now it comes to a sudden stop. And so it was accelerating and then sudden deceleration, and the axons get stretched, the fibers that connect the various brain cells. So we call those axonal. They may be strains, they may get torn and deteriorate. And then a real critical problem is rotational injuries. The upper part of the brain is connected to the spinal cord by the brain stem. And that's really our critical areas: heartbeat, respiration, reticular activating system. I'll show you an injury there, what keeps us alert and conscious. So rotational injuries cause a lot of shearing. Diffuse axonal injury is the sort of the hallmark lesion of severe traumatic brain injury, particularly when it occurs in the brainstem. But it is common. Somebody, you'll say, well, look, they just have this big bruise on the left front part of their skull, but it's not just that part of the brain that was injured. All of the connections inside the brain were injured. You can grade diffuse axonal injury if just the part between the white matter and the gray matter, that ribbon of tissue on the top, that's a grade 1. If it involves the corpus callosum, the part that connects the two sides of the brain, grade 2. And now, remember that rotational injury I talked about? If we get down here in the brain stem, midbrain, pons, medulla, this is cerebellum back here. This is the most severe. This is a grade 3. But interestingly enough, a lot of these patients get better. So this quote I use is, I hear it all the time from other doctors in acute care, who then send the patient for rehab. And I try and always get the patients to go back to the ICU, see the doctors, so they can see what their good work did. And they'll say, I didn't know these patients got better. So stage 2 and 3, just the terrible ones, 43% survive. Look at this, 62% regained consciousness, and the mean, the middle part, delay of, what is this, 3 weeks plus or minus another 2 weeks. So take it from a week to 5 weeks. And as we talked in those other studies, it's very difficult to predict who will live and who will die, who will have an acceptable outcome and who will have an unacceptable outcome. So we need to be very careful. Different types of skull fractures and open head injuries. This is a CT showing the bone lesions. Here's a big temporal bone open fracture, bone fragments being driven into the skull. And this obviously needs to be, you need to clean it out. A lot of times people get a methyl methacrylate plate put in. And then missile injuries. We see people who get shot in the head and survive and do pretty well, and others that do terrible, and others that die. And it has to do with the velocity of the missile. So a .22 caliber pretty much just destroys where it goes. And I've had lots of patients who got shot with .22s. They may have had problems afterwards, but they survived, and the problems may have been pretty focal. High velocity missiles create a shock wave around it, so that as it goes through the body, it destroys a lot of tissue. Military grade weapons are high velocity missiles. You may have a little .22 rifle for target practice, but if you go hunting a large animal, you're going to use much higher velocity to try and take, what am I trying to say? I'm trying to try and create enough damage to either, if you're going hunting, to kill the animal. If you're in the military, you want something also that's going to cause significant damage. How about closed head injuries? Focal, contusions or bruises, hemorrhages are a blood vessel breaking, infarct, like a heart attack or stroke, we can see that, but mainly most of the severe and moderate severe are axonal injuries, diffuse axonal injuries. We talked about that. But this is one we frequently miss, the hypoxic ischemic damage. So that person is in a car accident on the highway and their lung is collapsed, so they're not getting enough oxygen to their brain. Their spleen is ruptured, their blood count's going very low, and they're taken to the acute care hospital, and they get a chest tube put in, they get their spleen taken out, and they do well. And they're in the ICU, and they get out of the ICU, but their family says, my husband's not quite the same. And the problem is that while all this other stuff was going on, they weren't getting enough oxygen to the brain, and their blood count was low, so they had a hypoxic ischemic injury. And in the previous lectures, I say that one of the most important questions you always need to ask the family is, do you think that your loved one is any different than they were before? Because they may be walking around and seemingly doing well, but have a significant diffuse injury. So an epidural, remember we said this is the thinnest part of the skull on the side, and fractures are common. Well, there's a major artery that goes here, the middle meningeal artery. Goes right through here. Here's the dura. So now we've got this space between let's go over here to the side, between the skull and the lining, that dura. Now, if an artery gets torn because of that fracture, arteries are under high pressure. So we get this big time acute bleed in here. Here's a picture of Frank Netter illustration to the right. You can see this big clot forming. It's going to cause the brain to herniate. And when the brain herniates, the patient stops breathing and has a respiratory arrest. This is what an acute subdural hematoma looks like. I didn't, but somebody pulled back the tough leathery membrane back here. So the skull's taken off. So this is underneath the dura, where the other one was on top. This is a very acute, obviously the patient did not survive, large acute subdural hematomas. You can almost see the brain coming out at you, almost like knife edges here, because we have this, here's the skull, and the brain can't go outward. It's not like if I get hit on the side of the arm and I get a swelling, it can go outwards, but if I get hit on the top of the head and my brain starts to swell, it can only go down and press on the brainstem and herniate. Here's a brain that's been fixed and then cut, and now we're looking from the front in. So here is a big intracerebral inside the brain hemorrhage, and all of this kind of grayish brownish material is edema or swelling. And so here on this side is a ventricle with spinal fluid, choroid plexus that makes the spinal fluid, and you can see all that swelling is pushing the ventricle. It's a slit, and as a result, the brain's going to herniate down upon that brainstem that controls heartbeat and respiration. Here's a subarachnoid hemorrhage. I guess the title of this slide is wrong, and I need to change that. But let's remember that this is a subarachnoid hemorrhage. This is the front of the brain, back of the brain, cerebellum, brainstem. And remember that shiny membrane that I showed you? Now an aneurysm or blood vessel broke and tore underneath, and blood went everywhere. And the brain is pretty persnickety. It likes blood inside the blood vessels. It doesn't like it outside the blood vessels. And it can cause the arteries to go into spasm and cause strokes throughout the brain. Here's a brain flipped upside down. This is fresh. This brain hasn't been fixed. And so you kind of turn this around in your brain, since we're looking at the bottom. And the front of the skull would be here. So the brain slammed forward into the skull, causing these frontal contusions and bleeding. Here's the temporal lobe. Remember, we jumped down from the front of the brain down into the skull where the fractures occur. Well, the other thing that occurs is that the brain, as it went forward and this part of the brain slammed into the bone, so did the tip of the temporal lobe. And we see these temporal lobe contusions, frontal lobe contusions. This is on the outside. So we know now this brain moved like that. This patient's also going to have diffuse axonal injury from the axon stretching. Now we're going to go down into the brain stem. Let me see if I can go back. Yeah, let's go to this one just to show you. And even though, again, that's labeled wrong, the brain stem's sitting here, and here's the cerebellum. And what I'm going to do is kind of cut this open and take a look inside. So these are kind of mirror images because we cut it open here and tipped it upwards. And this is that pons, the middle portion of the brainstem. And if someone has a rapid rise in the pressure in their brain, they'll get these hemorrhages in the brainstem. These are called Duret, D-U-R-E-T, hemorrhages named after Frenchman. And this is see them on both sides, but what right here, there's something called the reticular activating system. So it goes from the pons up into the midbrain, and it's firing. It's why I'm awake right now, and hopefully you're awake. I'm keeping you awake. And it's about, maybe as big around as the head of a pin, could be a little larger, and an inch and a half long going up and down the brainstem. And it's what wakes us up and keeps us awake. Now, the ability to pay attention, if you're paying attention to this lecture, that's frontal lobe. That's different than divided attention, whole different level of activity. But just waking up, so waking up from a coma, you would have a problem if you had severe lesions involving the reticular activating system that sits right here and had hemorrhages here. So the rest of your brain might be relatively intact, but a hemorrhage here could keep you or the patient in a coma for the rest of their life. We're going to look at some MRI scans, and if you remember that brain I had upside down with the bruises on the tips. So over here on the right, this is the front of the brain. Back of the brain, this is frontal lobe. So this is what a contusion, big bruise would look like inside the brain. And we could say, wait, so this slammed up against the front of the skull. And that's the coup injury. And then when it came back, look at this one back here that hit the back of the skull, the contra-coup injury. So when we talk about contra-coup injuries, it's the brain moving inside the skull, slamming up against the front of the skull, and then getting here the back of the skull. We're going to drop down a little bit, and remember those hemorrhages I showed you, the bruises on the tip of the temporal lobe? This is that tip of the temporal lobes, and here's then a hemorrhage in here. These are eyeballs here, optic nerve. Here's the brainstem, basilar artery. We really get these beautiful views, and we're going to see some hemorrhages back in here again, just like we saw on, this is a different slice, higher up in the brain. Here's another example to show you of how bad it can get. Here's where somebody really slammed up against of the front of the skull, probably high velocity injury, say probably an automobile accident, and big bruises on both sides of the brain. And this is a view of the side of the brain. We call this a sagittal view. So the nose is here, front of the frontal bone here. Here's the back, cerebellum, brainstem's going to be in here. Well, here's that frontal hemorrhage. And remember those olfactory bulbs are right here that we smell with? So that's why most patients with severe brain injury lose their sense of smell. Sinuses are here. Now, brain tumors are a whole different story. And it's frequently a focal lesion. And focal lesions like stroke behave, let me start over. A brain tumor is usually a focal lesion and is more likely to behave like a stroke, and initially causing, let's say, paralysis on one side of the body, numbness on one side of the body, depending on where it is, vision problems, memory problems. And then as you get increasing edema around the tumor, it may cause more diffuse effects. Spent a lot of time in other lectures on encephalopathy. Encephalopathy is basically anything that happens to the brain. So those are diffuse lesions. And the reason I put it in here is because it's not just traumatic brain injury. We need to think in terms of acquired brain injury, things that happen to people that can cause diffuse problems through both sides of the brain. And here's a list, and I cover it extensively in our short and long-term consequences of critical illness lecture and 3 important rehabilitation diagnoses. The key, though, about encephalopathies is that patients that have been in the ICU, usually for more than 7 days, been critically ill, 70 to 100% of them have cognitive impairments at the time of discharge. And at 1 year, let's say about 2/3, and 2 years, 1/3. And we tend to miss it because they go back for follow-up and they see their doctor and how's your cholesterol, your blood sugar looks okay, you're walking well. And these folks go on with significant problems with attention, concentration, memory. What makes us most successful? Executive functions, planning, judgment, organization. And so we need to look for this. And again, it's covered extensively. If you're interested in more, go and look at the 3 important rehab diagnoses and short and long-term consequences of critical illness lecture. So let's talk about the symptoms of severe traumatic brain injury, the problems that patients have. And if you've listened to any of my other lectures, I'm always put things in 3 and say anything that happens to the brain can fall into 3 buckets: physical problems, cognitive problems, and behavioral problems. So if somebody asks you while you're making rounds, well, what do you think this patient could have? Or you're see a patient and you're trying to do your evaluation. I used to do this in the office all the time. Somebody came in, it had a brain injury, and I'm thinking, okay, let's go through in my mind, ask them about the physical problems. And I'm going to ask about the cognitive problems they could be having, and then the behavioral. Now, the physical comes pretty easy to us to remember. Paralysis, spasticity, speech problems, headaches. We don't see headaches that much in severe and moderate traumatic brain injury. It's almost the signature lesion in mild head injury. If you're going to take care of mild head injury patients, you need to also be a headache doctor. Seizures in closed head injuries, very small incidence. Open head injuries, whole nother story. And double vision, those cranial nerves get stretched. But that's about all I'm going to say about the physical problems, because they are rarely the limiting factor in the recovery of a patient or what they can do. I have had many patients who run companies in a wheelchair, travel the world, and we do a pretty good job with physical disability. Think of spinal cord injured patients. But what really is a problem are cognitive deficits and behavioral deficits. So Remember we talked about executive functions, the ability to pay attention, concentrate. They have problems with divided attention. So initially just starting to pay attention, think about the brain injury patients that you see and how inattentive they are and how easily they are to distract. You have to start their therapy in a quiet, distraction-free environment. You may have a satellite gym at your hospital, but you certainly can't usually take these patients to the big gym where all this activity is going on. And then initiation. Frequently they're just sitting there and they may not initiate anything until you ask them, well, how are you doing? And if you don't wait, because of their slow speed of information processing, you may run right over their thought process. I've seen physicians go in and say, hi, how are you doing? You having a good morning? Everything going okay? Okay, see you later. And the patient's still processing that very first statement. Executive functions are a big problem. Initiation, as far as getting back to work, now initiation, we lose that with age. I mean, I've noticed that. I'm looking at my desk, and I get different color file folders of projects, and it's easy to kind of, I'll just wait. I'll do that tomorrow. I think I'd rather record a lecture today. People after a brain injury, let's say you have a student who's getting ready to go to college, you say, well, I need you to go online, check out the classes, come back and give me a list of what you think you'd like to start with. And they come back to see you the next week. Well, did you get that list together? No, I'll get it done. So goal direction gets to be a real problem. Judgment. Who's the best physician, the best nurse, the best therapist, the best teacher, the best lawyer? We can go down the whole list. It's the person with the best executive functions. And judgment, the person who makes the right decision at the right time. And frequently, I think we'll cover it in the behavioral slide, a lot of these folks are impulsive risk takers to start with, and their judgment may not be great to start with, and then it's worse over time. But we do therapy, right, for these cognitive deficits. But what about behavioral disability? I think this is the most difficult. This is a quote from Barry Raff, and I like this quote. It says, that which makes us most human is most vulnerable to head injury. So one of the things that makes us most human is the ability to form relationships. I guess we don't always form the best relationships, because if you look at the divorce rate, which is sky high. Now, I'm old. I'll have been married 53 years this year. So if I have a brain injury, though, the person that my wife fell in love with all those years ago may be a totally different person. So that which makes us most human, the part that she really fell in love with, that she liked, that she's been willing to put up with all these years, now is affected by that brain injury. So brain injury exaggerates pre-existing personality traits. So if your patient was a sociopathic, drug-abusing, alcoholic, difficult human being, it's not going to be better. Who gets brain injury? Maybe 15, severe brain injury, 15 to 25, risk-taking men. And I've had families say to me, oh, my son is so mellow right now, after his brain injury. And I am thinking, well, just wait. Where we're headed for is this exacerbation of pre-existing traits. On the other hand, one of my patients was the Methodist youth minister, the nicest guy in the world, and he remained the nicest guy in the world. Apathy, loss of energy, that loss of interaction, very common. The big one is social inappropriateness and lewdness. Now, we all tolerate people that are slow. If I'm giving this lecture in a lecture hall, I'll say, well, look to your left, look to your right. Do you think, you're smarter than the person next to you? Or do we all have friends that are, we wish they would just, be a little quicker at what they're doing? But we all tolerate that. It's like going to the grocery store and you have the checker who's slow. I won't tell you my wife's theory on which line to get into based on who the checker is. But we go, okay, I can do this. Or you go to the grocery store and they have somebody who is developmentally disabled helping you take out your groceries. This is all pre-COVID, not since COVID, and hopefully we'll start again. And you're in a hurry, but you go, oh, but this is a good thing, so it's okay. So we tolerate that some people are slower than others. But we don't tolerate social inappropriateness or lewdness very well. So if one of your friends is really inappropriate, they may not be your friend for very long. Or you meet people and say, I don't really feel comfortable around this. Well, now think about you're the parent and you're taking home your 18-year-old socially inappropriate, lewd son who's had a severe brain injury, and your 14-year-old daughter wants to have a sleepover with her friends. It's a real problem. Boisterous, profanity, risk-taking. It's an exaggeration of a lot of who these people were to start with, these young males, risk-takers, impulsive and easily distracted. We did a whole lecture on the effect of TBI on aging, so I'm just going to I like this graph, so I'm just going to quickly go over cognitive reserve, because we're all born with a certain amount of cognitive reserve. Some people are smarter than others, have a higher IQ, and have more to give. And now we have this brain injury, the blue line, and they recover. And you can see the blue line over time, they're going to get to here before they reach their dementia threshold. And the yellow line, the yellow line was aging only, was here. So brain injury does seem to have an effect on it. But the question is, does it really speed it up? That's the purple. If someone has a severe traumatic brain injury, does it really speed up the aging process and that they're going to reach that threshold a lot earlier? Controversial, and the final decision's still out. Now, if you look at severe brain injured patients, unmet needs 1 year after their severe brain injury, it's not surprising. They wish their memory was better, problem-solving skills. The behavioral side, they don't manage stress and emotional upsets as well, controlling their temper. We've all taken care of patients or known of patients where the family tells you it's like a light switch. I mean, we're sitting around, everything seems like it's just fine, and bam, all of a sudden, Joe just goes off. And it's a huge problem. How about improving one's job skills? Because as I'll talk about quality of life here in a moment, we all like what we do. We have an idea, a perception of who we are that is important on our quality of life. And now we're probably, if we're able to return to work after a severe brain injury, having to accept working at a lower level. So what represents quality of life? It's been a real challenge this last year with COVID. I'm recording this on, May 5th, 2021. So we're well over a year into this. I forget the percentage we do have vaccine. We've got a good percentage of the population getting vaccinated now, and things are starting to improve. So you may have said, well, quality of life hasn't been that good. But if you ask people, do you think people with disabilities want less than people who are able-bodied? The true answer, if they're, no one's listening or, they're not worried about being heard, is that, well, it's hard for them to imagine that somebody in a wheelchair, somebody with a severe disability would have the same goals in life for quality of life. Well, guess what? They do. So this is from Janae, who did the Glasgow Coma Scale, and said, well, what represents quality of life for both able-bodied and people with disabilities? Well, activities of daily living, able-bodied people just take that for granted, right? Get up, go to the bathroom. I used to be able to get out of the house really quickly, up, get everything done, dressed, brush my teeth, whatever, and out. Now it takes me a lot longer, but I'm still independent in all of that. Now you've had a severe brain injury or a spinal cord injury, and it takes so much longer. And can you do it all? So ADL's huge factor in quality of life. One of the highest correlations of self-esteem, whether a patient goes home after a stroke, is continence, bladder and bowel. Mobility life organizations, go where you want to go, be independent. One of the real big things with aging is, losing your independence in driving. But let's say we're in a lecture hall and you're listening to this lecture and you've got to go to the bathroom. Well, you just get up quietly and go. I noticed it, but you did it. Now, well, you're stuck. You got to wait for somebody to come help you with it. But we do a pretty good job in rehab with those first two. But boy, how about the others? Social relationships. So think about that. You have this network of friends. I always say we're all kind of an acquired taste, but we have our friends that we like to do things with, we like to be with. And now I've had a brain injury. Has that network of friends changed? Because all the people come to the hospital and tell the spouse, oh, just let me know whatever you're going to need, and what can we do? Now, what I tell families is when people tell you that, say, right now I don't need your help because, boy, they're really taking good care of Richard. But when we get home, I'll bet could you come over and sit with Richard for 2 hours, once a month, every 2 weeks, so I can go get my hair done, go to the grocery store, just go see my grandkids, take your choice, and kind of put people on the spot. But the other thing about social relationships is, trust me, I've been married a long time, I said, and there's things that my wife doesn't like. But because there's the part there that she really fell in love with, she puts up with the other. Well, let's say now I'm on my own and I've had a brain injury. Before, if something happened to my wife, there's probably somebody would go have a cup of coffee with me at Starbucks. But now I've had a brain injury, or even just in a wheelchair and cognitively intact. Has that group of people that are willing to go have that cup of coffee with me changed? You bet. It's changed significantly. And it's a tough one. Because in rehab, do we stay there and help patients with that? And yes, there's organizations and support groups. But this is a real problem. And how about work? The level. I was the medical director of our hospital in San Antonio for over 30 years. And I used to say, if I had a brain injury and came back and I would start to head to my office, somebody might come to me and say, "Whoa, Dr. Senelick, we're going to start you off in filing and doing some filing that we have, or maybe just organizing these things we need organized." And I go, no, you don't understand. I'm the medical director. So the level of work is important. How do we get people with brain injuries and severe disabilities back to a level of work? Because most of us really identify with work, and we spend probably more time with the people at work frequently than our family. And the last two are critical. How satisfied are you with your current situation in life? Well, yeah, you can complain about some things, but overall things are really pretty good for most of us, right? But now you have a severe disability. And my job as a rehab professional is I've got to get you to the point where you say, well, I've had a bad stroke and the right side of my body's paralyzed, but I'm okay with this. I have figured out how to adjust, and I'm satisfied with my current situation in life or after a brain injury. And that's our job, to get people to that level. And then the last is future prospects. If you thought that as good as your life was ever going to get was listening to this lecture, I would worry about you. But, we're all sitting here. I'm looking at the thing. I'm starting to get hungry. It's 12:35 here in San Antonio. And I'm thinking, well, okay, I'm just about done with this lecture. I'm going to either go see, what's in the fridge, because we've been all working from home for about a year. Or maybe I'll run out, get some bad fast food. what else do you have planned? Oh, COVID's opening up and maybe we can actually go on vacation, all that, the things I've delayed. And Mother's Day is coming up and I'm getting together with, I'm not my wife too, for Mother's Day with the grandkids and the kids and coming back from college. We're all going to get together, the grandkids coming back from college. So we all live for future prospects. How do we, as rehabilitation professionals, give people with disabilities future prospects, things to look forward to? I'd really like you to somehow get out your phone, your iPad, take a picture of this image and go back to it, because I think it should really be involved in your daily life. And I'm going to leave you with one of my favorite quotes by George Eliot. George Eliot, English author, really Mary Ann Evans, wrote Middlemarch, Silas Marner, you may have read that in high school. Back in the 1800s, interesting woman, liked to smoke, drink, and didn't make much of a living as Mary Ann Evans, and changed her pen name. George Eliot became very famous. I like her quote. She has lots of quotes. So if you go on Google and Google George Eliot, I used one of her other quotes the other day in a lecture I recorded. I can't really remember exactly which one, but I love this quote. It's never too late to be what you might have been. So someone could say to me, well, why are you taking up another instrument? Or why are you decided that you want to, learn to do something? At your age, does that make sense? And say, well, you could say the same thing about people with disabilities and our brain injured patients. Maybe, are they too old? No, they're 75. Should we really do aggressive rehab? It's never too late to be what you might have been. I have this as a magnet. I have it in places, and it kind of reminds me of what we need to do. So with that, I want to thank you for joining me, and we have lots of other lectures. If you have any questions, you can always submit them, and we'll try and answer them for you. So thank you for joining me, and till later.